everyone. My name is Gustavo Saposnik. I'm the editor-in-chief of the World Stroke Academy for the World Stroke Organization. Today we have the privilege of having a friend and colleague, Dr. Michael Hill. He's a professor of neurology at the Department of Clinical Sciences at the Hodgkin Brain Institute in Calgary, Canada. He's also the president of the Canadian Neurological Science Federation and also the senior medical director of the cardiovascular and stroke program, also in Calgary. So thank you, Michael, for being with us. A great pleasure.
Thanks, Gus. Great to be here.
So why don't we get started with, can you tell us a story about the reflections from the ESCAPE trials?
Sure. Yeah, thanks, Gus. So obviously a great, certainly one of the highlights for me in terms of things that I've been involved in was running ESCAPE and that trial. But it started for us in Calgary because we were heavily involved in IMS3. So leading up to IMS3, we participated with Joe Broderick and the group from Cincinnati in the precursor trials, IMS1 and IMS2, where we were using intra-arterial alteplase, and we didn't have any devices at that point for treating stroke. And it was clear that there was a potential opportunity there for treating people. And then when we moved forward and helped with the grants for IMS3, and myself and Andrew Demchuk were on the steering committee for IMS3 and running that study, we were the core lab. So we were looking at the imaging as that study was coming through and seeing what was happening in the study. And then when Mayank Goyal joined us in Calgary, about halfway through IMS3, he also joined the steering committee and became involved in that study. And as we were seeing that study come forward, we were, as you know, we were really interested in imaging in Calgary. Aspects came from here, from Alistair Buchan, and we were pretty convinced that there was a strong role for imaging in predicting who you should be treating. And I think the other thing we noticed about, in particular with IMS3, and Joe noticed it too, and we talked about it on the steering committee, was that we thought there was cherry picking going on, right? That people were treating open label with devices that were being developed with the Mercy Retriever and others, and weren't enrolling consecutive patients at their sites. It was also a time when CT angiography was just beginning to be used more widely in stroke. And so, half the patients were having CT angios and half weren't, and that was sort of in clinical routine. And we saw that some patients were being enrolled in the study, but did not have a target proximal vessel occlusion. And so we were worried that some of these factors were going to influence the outcome of IMS3. And so then when IMS3 was neutral, and then in parallel, synthesis was neutral and MR rescue was neutral, all three papers at the same time in 2013 in the New England Journal, we were fussed about this, and we had been thinking about, well, how can we move this forward? Parallel to that was the development really of the first stent retriever, which was the Solitaire device. As you may know, originally the Solitaire stent was the Solitaire AB for aneurysm bridging. And it was really a serendipitous discovery that it turned out to be the open cell stent format seemed to be a good way of actually snaring thrombi. And Mayank had used it a couple of times, and we had colleagues in Europe who'd used it. And so we actually approached Medtronic we actually sat in a little coffee shop or bar with the medical director of Medtronic and the neuro lead, and we said, look, you guys, it looks like you've got something here. Would you fund us to do a trial, right? And this was I think it was in February. It was in one of the stroke meetings, and they initially said no, we're going to do our own trial, and who are you guys, and whatever. But we persisted, and finally they said, yes, we'll give you a small grant, and you can be. And I think it was like 1/30 of what they were planning to spend on Swift Prime. And they said, well, we'll consider that an insurance policy, right? That was direct words, right? It was quite interesting. And so then we proceeded to develop ESCAPE and the protocol. And as you know, half the sites were Canadian and had a big Canadian role. And We attracted other sites in the United States and Korea and Europe. Again, people that we'd interacted with, and then really the rest of it was history, and I guess really good. I'm in some ways proud of that trial in terms of everybody who participated. There were 25 sites that really signed on. We had 22 that finally enrolled patients in the trial, and one of the really good things about that trial is we were fast, and I think it's something we did. I was one of the things we did with Mike and myself and Andrew, and we really emphasized to the sites, and every time I went to visit someone, you've got to be fast. You've got to be fast. And it's something perhaps we didn't do as well in IMS3. We weren't quite so aggressive with sites to say, come on, you've got to move the bar. And I think that's one of the reasons why we showed a mortality benefit in ESCAPE where it was not seen in Swift Prime and Revascat and Mr. Clean and stuff, is exactly because from door to needle and the speed of treatment in ESCAPE was so fast. So it was really terrific. And the last thing I'll say, guys, which was really from the Canadian perspective, but if I thought, maybe even the most important thing about the ESCAPE trial as evidence of how important doing clinical research is, that basically as soon as we announced that the trial was stopped for efficacy in Canada, we had 11 sites in Canada, and there now are about 25 or so doing EVT in Canada, right? But those 11 sites turned around and started offering this therapy right away. And so it was probably the quickest sort of knowledge translation, or moving stuff into practice right away. And that was, there were lots of reasons why the circumstances came together to allow that to happen. Like we had aneurysm treatment before, and we had neuroradiologists, and we had angio suites, and so it was possible. We had stroke teams who were geared up to treat fast, but the study was good, right? It paved the way for people to do it. And so it was really wonderful to be able to say, look, we've finished the study, and we've in the next year turned around, and people were already treating lots of patients. And so I think that's a very gratifying thing, that we were able to move a study result, or it was 5 studies really, right? Once they all came together, and move that so rapidly into practice. And as we all know, it's a big effect size, and so gratifying to see our patients no longer staying on the stroke unit for weeks and weeks, but in fact moving home. So yeah.
So quick question then, you mentioned, ESCAPE was also a paradigm shift in terms of the concept of collateral flow, and that was something new. And the question for you is, since, the 5T trials that you mentioned, there hasn't been too much innovation other than the next question that will be related with neuroprotection.
Yeah.
So,
you're right. There's been a lot of incrementalism in thinking about what to do. So first was time window, right? Is the time fixed? Can we, and the answer of course is no, it's not fixed, and time is really just another variable that we should consider, but it's not a threshold effect for treatment. So we had the Dawn, Diffuse 3, and others going, and then we've had people looking at more distal occlusions, and I guess the big one recently is withholding IV TPA. Can you go direct to angio? And then the large core trials, right, which have suggested that, which I think are interesting, because that throws into throws into sharp relief the issues of, what can you use for imaging to decide who you should treat. And I think we've seen an interesting. It's interesting to think back, right, Gus? You remember, Gus, when we were doing, for example, the desmoteplase trials. It was in an era when MR diffusion perfusion mismatch was sort of the key thing. Everyone thought we can actually measure the true theoretical model of stroke. Turns out we're actually not as good at it. And then with CT perfusion, it seems in many ways the same thing, that there's enough error, and it is probably not fully correct that we can identify in detail that PET-defined true core and true penumbra with our current imaging paradigms. Even aspects or diffusion imaging, it's clear that large areas of diffusion lesion positive or low aspect scores, you still might be able to see a treatment effect. And it seems clear that prognostic factors are critical. The imaging is becoming a strong prognostic factor only, not so much something that modifies the effect of treatment. It seems so. That's really interesting, right? But I think you're broadly right that it's been incremental, and the next phase set of trials to come out will be on distal occlusions, right? So we're doing one with Escape Mevo. You guys are participating at St. Mike's, but you're right. These have been incremental steps in trying to figure out where, what are the boundaries of this new therapy, the endovascular therapy.
So if you apply some concept in terms of a strategy from the corporate world, what we have been seeing in the last few years, couple of years, is the segmentation. So we are now, microscoping, small groups that may benefit. You mentioned large score, low NIH, and there might be others. So it's a big investment for a relatively small effect size. Can you comment on that? Do you think that this is the way of science or a stroke care is going to evolve, in terms of making a progress?
Well, you go back, honestly, I'd just go back to philosophy. That seems to be how science goes, right? I mean, Karl Popper said it, right? You have a big jump and then you have a bunch of incrementalism. And you're right. I mean, that's part of what's happened. In terms of on the industry side, I think some of those things have been driven by, where the innovation, where the money is, right? Where are you going to get paid? And if you develop a smaller catheter, this, that, and the other, does it, where is that stuff? So that does drive where trials are done. What can we do next? Think about where the problem is. It's still true that a lot of our patients do poorly, even with treatment, and so we have to figure out, well, why is that? I mean, the problem of the large core issue is that a lot of the damage is done, and then you say, well, can we rescue that? Well, that's not really so much. It may or may not be a problem of acute treatment. It might be a problem of rehabilitation and other restorative kind of therapies.
Okay.
Well, we've all talked about those things. Is that's a clear frontier for us, right? It appears that the nature of human stroke and other conditions too is that a lot of times we get people who are in an advanced stage of disease. So in the acute stroke, that means they've already got a lot of injury, and we may not be able to reverse that injury. We may be able to halt that injury. That's probably what reperfusion does. It halts the injury, and then you still have to deal with the repercussions of that injury, and that will be recovery. And some of that right now, the recoveries are, things we're doing are also pretty incremental because we haven't had a breakthrough in recovery either, right? And in terms of
agree
to do, and I think we probably need that, right? We need to figure out what's the best way to move them forward, right?
Agree, but I would like to take your words regarding, it's interesting that acute stroke neurologist is thinking across, along the continuum. Most of trialists are not thinking that it sounds that, a stroke is going to evolve in the way of having a more global conceptualization. And I will go to my last question then. But before doing that, question for you relates to the NA story, so the NA1 trials,
Yeah.
So you started, mention about the importance of the time window with Escape, the original trial, but then the story sounds with Frontier to tell us exactly the same. Can you elaborate a little bit on that? It's interesting.
Yeah, so I mean, obviously the conceptions around so-called neuroprotection or cytoprotection have evolved a lot, and of course in the early 2000s lots of drugs were tried, and the failure of those drugs may have been predicated on the fact that much of the animal models which suggested benefit were ischemia reperfusion models, and then when they were translated into humans, for one of the issues was that much of the time we were not getting reperfusion, right? And so the evolution of endovascular therapy allowed us to overcome that bar. but there still may be other things that we haven't sorted out. And so interestingly, as we moved through with nerenatide, the first stuff with enact was a way to just suggest that it might actually be beneficial in aneurysm coiling. And then we did escape NA1 in exactly following on that paradigm from escape of early reperfusion, give the drug. And it looked like it might work in the population that was not getting alteplase. So there was this pharmacological interaction, and we had a 12-hour window in those populations. So Escape Next, which is a neutral trial, we're going to try and publish the two together with Frontier, but and we presented at the World Stroke Congress. It's hard to know exactly why, right? It was almost identical to Escape NA1, and we've reproduced it, and it may well be that given data from Frontier, which suggests that early treatment is clearly the issue, and you benefit most from early, which follows along from all the previous data we've had in stroke. It may be that we just got the wrong population in Escape Next, and really what we needed to do was treat earlier. The average time to treatment was about 4.5 to 5 hours in Escape Next, whereas in Frontier, it was 1 hour. So maybe those 4.5 hours matter. And maybe with neuroprotection, really the target population is that ultra early group, and you'll so-called freeze the penumbra and allow you time to get reperfusion. These are still hypotheses, right, which need to be proven in the real world. And so that's the next step. We hope to do that. But I think, yeah, it's interesting. Science is hard, man. That's what it comes down to.
So in Frontier, they allowed for thrombolytic therapy. Am I right?
That's true, but it was given after you gave the nerenatide. As we've discussed, one of the critical features of this potential interaction of thrombolysis plus nerenatide is that if they're given together, the two, like alteplase and nerenatide, or tenecteplase and nerenatide, at approximately the same time, you definitely get cleavage of nerenatide. If you give nerenatide about 20 minutes or 30 minutes before you give the thrombolytic drug, then the nerenatide rapidly translocates into the brain and is out of the circulation, and therefore it's not available to be cleaved. And so in Frontier, of course, the paramedics gave the drug at the scene, and the average time from drug delivery to starting thrombolysis was about an hour. And so that is the putative reason why in Frontier we've seen an effect.
This is a great comment, because not many people may be taken into account, beyond the stroke experts. So now moving to the last question is, how do you see the stroke world moving forward? So how do you see or anticipate what is going to happen the next 10 years, let's say, in acute stroke care?
Well, one of the ways to answer that question is, is to ask yourself the question, why did my patient do well, but why did my patient who's still on the ward do badly? Right? What was it about that patient? And so when I ask myself those questions, there are a number of reasons. One is they came in too late, or they had extensive damage already, or they were very frail, or they had multiple comorbid conditions. There may be things that we can't resolve because they're there. But it is clear, if you ask that question about did patients get to us in time to offer current therapies, there are lots of people who don't get to us. And so working on systems of care are ways to increase the proportion you can get access to. So that's one thing. And probably we need to move some of our stroke work into the field, right? Somehow, right? And it's hard. That's super hard. Paramedics, all of those are, but there's going to be there must be an evolving shift that way. And so the research will have to move into the field to get there. We may still see improvements in therapies, right? So the critical issue appears to, at least at the moment, appears to be restoring blood flow. So can we make it better? It looks like tenecteplase might be slightly better than alteplase. The pooled this may not be widely known, but the pooled analysis of the UK trial ASSERT2 and the ACT trial in Canada suggests that indeed tenecteplase might be 1 or 2% better on outcomes. And so moving to tenecteplase is a good idea. Are there other drugs that will help open arteries? Perhaps there are. Sadly, the MOST trial was stopped for futility. So adding in the 2B3 antagonist or direct thrombin and antagonist did not seem to be helpful, but maybe there'll be others coming. We'll see where that goes. And then I think there may be the issue of neuroprotection might be there. We'll see. I mean, we've got to, you have to be hopeful that that's possible. Whether we'll get to, and then I think that the big open stuff is recovery, right? Where one of the things, I don't know if you've observed it, Gus, but I think certainly in our place, the evolution of endovascular therapy has actually made our rehab services busier because we're saving more people who need rehab. And so I think there's huge scope here for pushing rehabilitation agendas for that population. So I think acute, it's not just acute stroke. You've got to think about it across the whole agenda. And then I think lastly, I don't know what happens everywhere in the world, but I think this is true because it's the same paradigm as cardiology. We've looked at some data recently, the 10-year, if you have a stroke or even a TIA minor stroke, your 10-year risk of recurrent stroke is almost 25%, right? So if that's the case, what are we doing to stop them? The best stroke is the one that never occurs, right? So how do you prevent them? And then preventing a second one is equally as important. So there's a range of things that we still can improve on over the whole of stroke care.
Thank you, Mike. It has been a real pleasure having you. I think that you mentioned several concepts, very interesting concepts that I'm sure that the audience will really appreciate. So to finalize, before, if we have to quote you, give the shoes, but now it sounds that we will have to think about which shoes. It's not only one, we may have more than one.
I hope so. Thank you, Gus. Nice to talk to you.
Thank you very much. Much appreciated.